All right, thank you everybody for joining our Protocols, Medications, and Devices committee meeting. Please be advised that this meeting is being recorded, so anything said verbally, anything viewed via webcam, or anything typed in the chat could become part of the recording that we post publicly. Please mute your phone when not speaking. If you're joining by phone only, you may need to press *6 to unmute yourself. I think that's it. All right, go ahead, Dr. Kesterman.
Thank you, Shelley. Welcome everyone to the PMD Standing Committee. This is March 17th, 2022 call to order. Shelley, can we go ahead and start the roll call, please?
Amber Wright.
I'm here, sorry, Shelley, couldn't find my unmute button.
Thank you. Erin O'Connor.
Present.
Thank you. Brian Smith.
Present.
Chester Key.
Present by phone.
Franco Castro-Marin.
Present.
Garth Gamer.
Present.
Heather Miller.
Present.
Jason Johnson.
Here.
Jason Payne. Josh Gaither.
I'm here.
Matt Shaw.
Here.
Paul Dabrowski.
Here.
And Shari Brand.
Here.
All right.
We have quorum.
Great. So we have quorum for today. Thank you. All right. So we'll start with the chairman's report. Attachment 3A is the attendance report. Just a friendly reminder that if you miss 2 consecutive meetings, the Bureau will contact you to ask if you're still interested in serving on this committee, but there is an attendance requirement. Shelley, do you have to display that for the meeting purposes, or shall we move on?
Oh, no, we can move on.
Okay. Item B, the vacancy report for today. There is a need for someone to join from the Southeastern region as a representative. Please contact Sarah Perotti at the Southeastern Arizona EMS region. The email is displayed here on the screen. This role will be appointed by the Bureau's medical director after the specific region votes on the vacancy. There is no term limit. However, as mentioned, there is an attendance report. And on to the Bureau report.
Good afternoon, Dr. Chair Castro-Marin. We are here at the Bureau. We have some updates to share this afternoon. I'll start off by acknowledging that it is legislative session right now, and the Bureau of EMS and Trauma is tracking a handful of bills right now with potential to impact our state system. Please let us know if you have any specific questions. On the rulemaking side, we continue rule updates with work groups. Air ambulance rules are currently making their way through the formal process, while ground ambulance rules are still in the informal phase, and we continue to convene a stakeholder work group around ground ambulance rules. The department expects that we will have the next draft of ground ambulance rules available for public comment in a month or so. We are also starting to look ahead at workforce trends among EMCTs. As you know, we continue to look forward. We want to make sure that Arizona has sufficient workforce to support our growing population, to be prepared for EMS and trauma challenges that lie ahead. Most recently, we have conducted a state and regional workforce needs and interests survey that was presented during the last Education Standing Committee meeting this morning, and we look forward to discussing and distributing those results further. Before I move on to the next item, I just want to plug the department will host a trauma program managers and trauma medical directors workshop in April. That workshop will be hosted virtually on April 28th. Please let the team know if you have any questions on that upcoming virtual event. And next, I will introduce one of our newest team members. Antonia Gerard has recently joined the Bureau of EMS and Trauma as our rate analyst working for the CON and rates program. She comes to us with a great financial and accounting background, and we look forward to introducing her to more stakeholders as she gets acclimated with the program. Antonia, thank you for joining us. It has been quite challenging for the Bureau in terms of recruitment and hiring. As many of you on the line know, we are in a very competitive environment in terms of recruitment and hiring, and we are fortunate for any of the staff that we have join us right now. So with that, I will pass it off to Dr. Bradley to talk about the naloxone Leave Behind program.
Thank you, Chief Garcia. As many of you are aware, we are continuing to advertise our naloxone Leave Behind program. Some of the data that was presented earlier this morning, for those of you that were on TEPI, demonstrates that we continue to have issues related to opioid overdoses throughout the state of Arizona. In addition, we do recognize that a higher percent of patients are sometimes not getting transported by their own choice after an opioid overdose. And so we recognize that the naloxone Leave Behind program is an opportunity to provide those patients with resources for potential recurrent overdose, as well as resources for substance use disorder. The link that is on our agenda takes you directly to this website where we have the training curriculum for the naloxone Leave Behind program. We also have a sample template pamphlet that your agency can print and also can customize with resources for your jurisdiction. The other link on here is to order naloxone. So this is through the Office of Injury Prevention. They provide a large number of EMS agencies throughout Arizona with naloxone for free. If you have any questions about implementing a naloxone Leave Behind program in your jurisdiction, I will add my email to the chat box. Please feel free to reach out to me, and I will turn it over to to Julia next to discuss share.
Good afternoon. Just a couple of updates on share. So as has been mentioned in previous meetings, the Bureau has been working over the last year to recollect information from cardiac receiving and referral centers across the state just to ensure that recognized hospitals have continued to maintain recognition requirements. So as of today, we've been able to re-recognize 35 receiving centers and 2 referral centers across the state. So we just wanted to thank you to everyone that's worked on that by either submitting documents to the Bureau or submitting data. We really value your participation in the program. And I also just wanted to add that CEDAR staff at the Arizona Emergency Medicine Research Center are hoping to get out the 2021 share reports much earlier this year. And we just encourage you to submit that data as soon as possible. Again, we wanted to thank you for your participation, and I will hand it over to Adam.
Thanks, Julia. Good afternoon. So far, our EMSC survey is moving along nicely. We have a few more weeks until it closes, and we're ahead of last year's numbers, so we're very pleased with that. The program is on its 5th year out of 5 of its grant cycle, and we have just received news that we are to be issued funding in the next few months so we can continue our efforts here. With respect to the ACES action plan, we have developed, the Bureau has developed an online interactive training tool for EMS, which can be found on our education page, and that is specifically aimed at reducing adverse childhood events and the outcomes associated with that. If anybody has any questions about those, I will put my name and email in the chat, and you can feel free to contact me. Otherwise, that's all I got.
Thank you, Adam. And I also want to just echo a warm welcome to Antonia for joining the team. I'm looking forward to meeting you in person someday, hopefully soon. We're now moving on to the discussion and action items. Item A is discuss, amend, and approve draft minutes from November 18, 2021, which is attachment 5A. May I get a motion to approve?
Move to approve, Jason.
This is Amber, a second.
Thank you. So we have a motion and a second to approve the minutes from the last meeting. Any discussion or amendments, please? Sounds like there's no further discussion or amendments, and we'll go ahead and take a vote. All those in favor to approve the minutes from November 2021, please say aye.
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 Any opposed, say nay. And it sounds like the ayes have it, and the motion is adopted to approve the minutes. Thank you. The next item is item B, to discuss EMCT scope of practice. Can I get a motion to discuss, please? Or is this an actual voting item, Shelley?
No, it's not.
Okay.
All right. Good afternoon again. This is Rachel Garcia again with the Bureau of EMS and Trauma. We wanted to make sure that we had this item on the agenda. We have previously discussed this with the Medical Direction Commission at one of the last meetings. There was a request to amend EMCT scope of practice. At this point in time, with the moratorium on rulemaking, we currently do not have approval to open up EMCT scope of practice and conduct exempt rulemaking. Without having approval for exempt rulemaking at this point in time, we have been able to review and approve a pilot project for paramedics to do ultrasound guided IVs in hospital settings. That was one of the requests to update scope of practice previously. We will certainly keep this group updated in terms of the rule moratorium and any approvals we do get to open up EMCT scope of practice moving forward. I think that's all I have on this item unless there are questions.
Any questions for Chief Garcia? All right, thank you, Chief. Hearing none, we'll move to item C, which is a discussion. It kind of dovetails into item D of hospital-based paramedic practice. I wanted to bring this forward to ask an opinion of from the members of this body if we feel that there would be a need or a benefit to having either some kind of dedicated subcommittee or standing committee, or just simply an item placeholder in future meetings where appropriate for specific questions as they pertain to hospital scope of practice or hospital specific questions. More and more those of us that are starting new programs are looking for areas to increase value of these team members. And it seems a little inefficient to sort of bring questions forward one or two at a time to somebody at the Bureau when either other folks who have programs that are more mature are already doing things or have found successful ways. Certainly the ultrasound guided IV is just one example of this. And so my thought is to create a more permanent memorialized safe space for discussion for specifically topics that pertain to this type of provider or this type of provider in this particular workplace environment. And so I put it forward to the group to see what seems to make the most sense in terms of how to weave this into our current regulatory structure.
This is Jason. Yeah, I do think it's something that we need to do, especially with the nursing shortage. We've ended up hiring a bunch of paramedics for the hospital, and by default, I was asked to be their medical director. So it is something that's relatively new for us, and it would be really nice to have some type of resource or a group where we could kind of get together so you don't have to reinvent the wheel, so to speak.
I'd be in agreement with something like that, or at least having a standing committee that we could keep going back to.
Yeah, my vision for this would be not only a forum to exchange ideas, but also a forum to which we can reliably bring questions forward, and for questions that don't have a specific answer based on current EMCT practice, on the current EMCT practice model, then at least a place where regulatory questions can be referred to, hopefully resolved, and if not, then create a flow of information up into the Bureau, and then for the Bureau to bring forward responses or regulatory solutions where available. Does it make sense, Dr. Bradley, to have it as a standing item on one of the committees that are currently in place? It seems like that would be the easiest solution, or does it make more sense to perhaps request the formation of a different standing committee?
No, I think I'm just looking at the comment from in the chat box as well. Regarding that, this does come up quite a bit as the trauma managers will serve, and I think that would be a valuable resource. So we can certainly add that as a future agenda item so that we have that as a standing topic. I think this is rapidly evolving, and it's such a new item here within Arizona as well as across the United States. But I think there is going to be some regulatory catch-up that does need to occur. So getting feedback where people identify gaps and barriers would be very helpful. So I think that's a great idea to move forward, and we'll make sure that gets added as a standing item kind of moving forward on the agenda.
Should we look at it also outside of this particular PMD committee? I mean, does there need to be something at EMS Council or Medical Direction Commission as well, or just kind of start it here and then refer items up the chain from there?
I think what we can certainly do is start it here and then refer items up, similar to what we've done with scope of practice. Is started with this committee, and then once there's kind of good feedback from this, it would go forward to EMS Council and MDC as indicated.
Is the idea to eventually create a new column in 5.1 for like in-hospital paramedic that would have a different scope? So I feel like my understanding is right now they could work in the hospital under their normal paramedic scope with whatever the local emergency department medical director says is okay. So they wouldn't need anything different necessarily. Is that incorrect?
So correct. The way currently paramedics working in the emergency department or in the hospital setting would be a paramedic just like they would be out in the pre-hospital setting. There are a couple STRs that were added, recognizing that those things aren't occurring in the pre-hospital setting. So things like urinary catheterization, ultrasound-guided IVs that can be done. That one's currently a pilot. Moving forward, that your other part of the question regarding is there a desire to build ideally a 5.1 per se or a hospital-based scope of practice? There's a lot of conversation that gets brought forward to the Bureau regarding critical care paramedics, both in the hospital setting, air ambulance, ground setting as well, and then also community paramedicine. So I think those are some of the things that we can certainly look at and try to figure out what would need to be adjusted in our rule to allow there to be kind of another essentially option for certification with a higher scope. But those are all really important as we see EMS evolving and kind of moving from strictly pre-hospital into the hospital setting. I do think those are things we need to consider.
No, I like that idea. This is Jason. Would it be worth putting together a subcommittee within this committee of those of us who are interested in this specifically? I see Greg Spurlock has also said just in the comments that he would also be interested. I think there's a handful of us that this really applies to that might be, a little more motivated or interested in getting this thing going.
So a recommendation from Shelley, who keeps us in line with all the open meeting rules. Thank you, Shelley. You keep us out of trouble. Is that we add this to the July agenda as a kind of formal action item. So if anyone would like to send kind of how they would like this to look on the agenda for July, I think this is great conversation, and we can make sure that it gets added to the July agenda with some specific discussion and action items. But a really good conversation. I think it's an important item to bring forward.
So this is Franco. So if there is a group of folks that might join with me to shape that agenda item, please maybe leave your contact information in the chat box, and I will reach out to you offline, and then maybe we can brainstorm this and come back with some more specific action item, whether it's the generation of a subcommittee or a standing items, standing meeting item. and then we can bring it forward for July. Does that sound reasonable?
Yeah.
Yes.
Great.
Sounds reasonable.
Thank you.
Sounds
Thank
good.
you all. Yep. Thank you. And I saw Dr. Gamer's recommendation as well. And so we'll take that all into consideration. Let's see. The next item D, is to discuss the EMS hospital collaborative patient offload plan.
All right, good afternoon again. At this point, Shelley, I'll just share with a copy of the plan if anybody wants us to project it while we're talking about this agenda item. Most recently, as we've been navigating through the challenges of the last couple years, there have been some collaborative work groups that have come together with both EMS agencies and hospital healthcare partners, wanting to come together to address things like ambulance offload times and increased wall times that we were seeing in so many facilities across the state. So we have today a copy of, we have a copy of an ambulance offload plan, very similar to the Southern Region plan that was shared at one of our last statutory committee meetings that we would like to share today. This has been approved by a collaborative work group that has met a couple times over the last month to review. And I think that we may have some time to go through it specifically as Shelley pulls it up. And perhaps we can solicit some feedback if there are any questions or comments on this particular plan. Dr. Bradley, if you don't mind, I'll pass to you next to talk through some of these different categories.
Thank you, Chief Garcia. So again, a big thank you to Southern Arizona. They had developed this process several months ago and have implemented it now, I believe, for 3 months. This was a really amazing collaborative work in the hospitals and EMS agencies in Southern Arizona for EMS and offload times. This was brought Maricopa County Department of Public Health from ADHS, as well as the hospital systems and EMS agencies. Can be done in a number of different settings. So there was a separate work group that looked at interfacility to see, do we want to implement a plan that was approved in Southern Arizona? So this was the only difference of this one is the Southern Arizona was color coded, kind of a stoplight format. The Central Arizona hospitals was that we did not be confusing with some of the trauma activation criteria. But the whole that we have kind of a process that we can set out as a best practice and get input from this group. Really, when you look at these 3 categories, the is kind of your high-risk patients. These are going to be your typical alert type notifications, so your stroke, STEMI, cardiac arrest, trauma, etc. These patients are going to need to get it. The next one, which is kind of on the bottom of the first page, which is your kind of your ambulatory waiting room patients. These patients are individuals who, if you do not have a bed available, if you have a surge of patients, that you would want to collaboratively have a discussion between the EMS agents, EMS personnel, and the nursing staff to ensure, could this patient potentially go to a lobby? Now, under ideal circumstances, when you look at this list, these are people who wouldn't necessarily want to put in the lobby, but we do recognize that we are, despite COVID numbers improving, still in a scenario where many hospitals have a high volume of high acuity patients. And so we sometimes do need to put patients into the lobby in order to get the EMS personnel back in service and be able to run additional 911 calls. The middle category is the one that's a little trickier. These are patients that typically are not waiting room appropriate for any number of reasons. And so these patients, there is a little bit of a increased amount of time with the goal offload time to not exceed 30 minutes for these patients. Part of this process is also an escalation plan. And with this escalation plan is recognizing we really want people, if they see a prolonged offload time, to route this up their EMS system, whatever your EMS agency's kind of hierarchy is moves that up through that system rather than this being a debate in the hospital between the bedside nurse and the EMS personnel. So getting them involved. So again, this is something that will be implemented in the central region April 4th. They decided that April Fool's Day was not a good day to go live with this. So this will go live April 4th with the plan to reconvene that group within about 30 days to see how it's going. The other part of this, if you can scroll down just a little bit further, Shelley, the pre-arrival notification. So this was something that in the central region, many of the agencies and hospitals did not want BLS courtesy notification. So they essentially had historically said, if you have a low acuity patient, just show up. We don't need to get radio traffic. With the volume of patients that hospitals are seeing now, they really all uniformly said in the central region, we want to get notified of any incoming patient because that allows us to really plan for where to put the patient. So whether it's high or low acuity, that pre-arrival notification, when possible, is really beneficial for the hospital to try to plan on offloading that patient and again, hopefully get that EMS personnel back in service. So that is kind of a very brief, high-level overview. Again, thank you to everyone that was involved in this process, and a big thank you to Southern Arizona, who really had the heavy lift of developing this and then testing this for the rest of the state.
Thank you, Dr. Bradley. Any questions or further discussion on this item?
Franco, this is Garth Gamer. I commend the developers of this, and I think that even though COVID numbers might drop off, I think the numbers of worried well that are probably going to be more willing to go to emergency departments for treatment is probably going to paradoxically increase. Even if COVID numbers are going down. I think we've seen that in our figures that we saw earlier regarding cardiac arrests. It seems like the numbers of cardiac arrests were going up, but the transport rate was decreasing, and I think that's probably because people waited till they were too far gone to even get transported. So I think that trend's probably going to reverse, and we need something like this going forward. So I'm all for this concept.
This is Sandy. I know I'm not on the committee, but I would like to make a comment or ask. Is this something that's going to be required or suggested for facilities? And the reason I ask is because at my facility, my two facilities, we have a very robust plan that's similar to this, but it's working very well. And I think to switch it now to a different plan would be a little more confusing because I only have 3 specific agencies that pretty much bring patients to our facility. So it's very easy for us to work with those 3 agencies. So that's my ask. Is it going to be something that's required or is it going to be a suggestion?
So Sandy, I would recommend that you discuss this with your hospital leadership and system leadership. This is not any type of regulatory function. There is no statute, rule, or anything related. This was really just a collaborative team of stakeholders that got together to try to address this. So I would recommend that you talk to your hospital leadership and then at the system level to decide that question. But there is nothing from the Bureau that is making this mandatory or required. Again, this is just an attempt to create collaboration between the hospitals and EMS providers to address the issue.
Thank you.
All right, any other questions on this discussion item? All right, hearing none, we'll go on to the next item, item E. Discuss, amend, and approve forming a work group to update the P3G guidance document. Can I get a motion, please?
So moved, Matt.
Second, Jason.
Thank you, Matt and Jason. So we have a motion to discuss, amend, and approve forming a work group for the T3G's guidance document. Any discussion, please?
Franco, this is Gail. I can give a little bit of background on this. The NESEMSA Model EMS Guidelines, the new version, was essentially ready to go and be published last month. The American College of Surgeons has updated their field triage guideline, and that is going to now be added to the NESEMSA Model EMS Guidelines. So that's the only reason that it has not yet been published. The new ACS field triage guidelines, 2011. So this is pretty. STAB reviewed and approved those and implemented the statewide eliminated pocket guides that the Bureau put together and distributed as well. But those guidelines are being ready to be published. What I would like, the ask from the Bureau, forming the work group. So once the Model EMS guidelines are actually published, we can start reconvening that work group to start doing the updates on the TTTGs. So we anticipate that the Model EMS guidelines should come out shortly and want to just get ahead of this. Otherwise, we would have to wait until July to potentially convene a work group.
Any other questions at this time from the body? All right, so having no further discussion, let's take it to a vote. All those in favor of approving to form a work group to update the T3G guidelines upon the release of the National Model EMS guidelines with those national updates. All those in favor, please say aye.
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 Any opposed? All right, the ayes have it, and the motion is adopted to form a work group to update the T3G guidelines upon release of the National Model EMS clinical guidelines.
And we can take names of any volunteers. I see Paul Dabrowski volunteered in the chat. Thank you. And Matt Shaw from Flagstaff. Anyone else?
Shelley, you can put me down again. This is Franco.
Amber, Franco. Sorry.
This is Jason. I can help.
Jason.
Shari, you can add me too.
Thank you.
Okay, anybody else who's interested, please let Shelley know so we can get a good dynamic and engaged group. It is a heavy lift, and so the more the merrier.
Well, we
Much
don't want to run
appreciated.
into a quorum issue. Actually, this number is perfect, so we don't have a quorum of PMD members there for
Got
our
it.
work group.
All right, so the next item is item F, discuss the status of the state emergency declaration.
All right. So on this item, I know we've covered it in the last couple committee meetings that we had this morning, but we wanted to make sure that we were making some time to discuss the status of the emergency declaration here in the state of Arizona so that stakeholders can begin to prepare and plan for what will come next as some of the waivers and other emergency measures will sunset here in the state of Arizona. As we start to really think through next steps, we know that the end of the emergency declaration will likely be in the coming days, if not in next week. And we want to make sure that we're thinking about the enhanced surveillance advisory, as it will be sunsetting as part of that emergency declaration. The enhanced surveillance advisory is what currently mandates a lot of the reporting throughout the pandemic. Hospitals, labs, and other entities that currently report data to the state of Arizona will no longer be mandated to do so under the enhanced surveillance advisory. However, We will switch over to encouraging most of those entities to continue their reporting, as some of the reports that come into the state are then funneled up to the federal level, and that will satisfy some of the federal reporting requirements that will continue. On the executive order related to the surge line, we expect that the Arizona surge line in its current form will begin to transition and look a bit different as that enhanced surveillance, as the emergency declaration ends. The executive order for the surge line will end. We also have an emergency measure in place currently that authorizes all levels of EMCTs to administer vaccinations and testing. That emergency measure will end when the emergency declaration ends. So we want to make sure we're starting to talk through and think about that will sunset. Our primary method to be able to communicate out to stakeholders when these changes do go into effect has traditionally been Gov Delivery over the last couple years. So we continue to plug Gov Delivery. If you have not subscribed to receive the Bureau updates, we encourage you to do so that we can send out those types of communications very shortly here. The other thing that I'll put on the radar is that with the emergency, there have been waivers and temporary professional licenses issued from a number of professional licensing boards. We know that there are still quite a few nurses and other professions out there that are currently working under temporary licensure. And right now we are tracking some legislation that would extend temporary licenses through the end of at least this calendar year, I believe. So that's something that we're keeping an eye on, and we believe will help us stay on track as we plan for the end of the emergency declaration here. There are a couple more items that I'm going to pass to Dr. Bradley to cover related to crisis standards of care now.
Thank you, Chief Garcia. So I just wanted to make sure for those of you that were not on the first two meetings this morning, we are really wanting to make sure that we get the education out there to everyone regarding the sunsetting of the declaration as that happens, that crisis standards of care will be sunsetted at that time as well. I'm sure many of you recall in March of 2020, when the emergency declaration occurred, the Bureau helped with stakeholder input, develop some COVID-specific along with some crisis standards of care. Those have been updated a couple times the onset of the pandemic. As the crisis standards of care are sunsetted, those guidelines will be well. So we want to make sure we know it was a huge on short notice, as well as educate your personnel regarding crisis standards of care. But as we hopefully continue to move out of this pandemic, we do want to give everyone as much notice as we can to start working on scaling back those guidelines and going back to more routine standards of care. I'm happy to answer any questions if anyone has any.
All right, so hearing no additional questions, thank you very much to the Bureau for providing guidance on that very, very important topic. Obviously, it's incumbent upon all of us to make sure that we're that our organizations are practicing in lockstep with these type of declarations and clinical level of care declarations. So, thank you very much. Item 6: any agenda items to be considered for the next meeting? Okay, and the call to the public? Okay, so upcoming events on the calendar here next month, we've got a couple. April 5th is the AHLS Advanced Hazmat Life Support Provider / Instructor happening down in Tucson, as well as through virtual format. April 7th, AHLS Radiological Incidents and Terrorism. And June 9th, the AIMS 22nd Annual EMS Odyssey Conference. And is that right? Is that happening virtually this year? Okay.
Yes,
Please.
Sandy, it is virtual, Dr. Castro Marin.
Okay, so no in person at all?
No in person. Next year, we are striving for in person.
Great. Thank you very much for that. Please visit the Bureau's news and conference pages for upcoming events and training program page as well for other upcoming CE opportunities. Our next meeting will be July 21st, 2022 at 1200 hours, location to be announced. And we will go ahead and adjourn at 12:40. Thank you all.
Thank you, Franco. Good meeting.
Thank you.